today. Ladies and gentlemen, medical education across the world is undergoing a very important shift. The focus is moving away from time-based training towards something that is far more meaningful, and that is demonstrated competence. Because in healthcare, time spent in training does not always translate into readiness for real-world care. Competency-based medical education, or CBME, is reshaping how future clinicians are trained by emphasizing skills, behaviors, and measurable outcomes. But moving from framework to implementation brings its own challenges. So how do we align curriculum with real-world clinical roles? How do we redesign assessment to measure competence meaningfully? And how do we prepare faculty and institutions for this transition? This next session will dive deep into the answers to these questions. To moderate this important discussion, please welcome Dr. Santosh Moses, partner, Grant Thornton. We have Dr. Santosh Moses here with us. I would also like to request all the people and all the guests to please take their places so that we can start this session and invite our esteemed panelists on stage. Ladies and gentlemen, quickly take your places so that we can begin this session. Joining Dr. Santosh Moses on stage are Dr. A. Rekha, Dean, D.Y. Patil Medical College. Dr. Rakesh Agarwal, National Chair for Disease Elimination, Indian Council for Medical Research. Dr. Nayanjeet Chaudhary, Senior Consultant, Government of Meghalaya. Dr. Vivek Sauji, Vice Chancellor, Bharati Vidyapeeth, deemed to be university. And Ms. Shailadi Gupta, CEO and founder, KindShell. Okay, Ms. Shailadi will be joining us soon. Dr. Santosh Moses, over to you.
Thank you very much. Can you hear me? Yeah. So thank you very much to our panelists and everyone assembled here for this very important session. I know after lunch it's always a difficult session to conduct, but I think the importance of the session should outweigh the pros and cons of sitting here after lunch and fighting postprandial lassitude. So let's start the session. If time spent in classrooms, were to produce great doctors, I don't think we'd be having this conversation today. But, healthcare is evolving very, very rapidly. With the influx of artificial intelligence, the pandemics, and the shift in disease patterns, the medical education piece is not really keeping pace with the changes in the healthcare and what's evolving in the artificial intelligence space. CBME is a great opportunity to bridge this gap, and also we have stalwarts in this field who, I'd like to invite to make an opening statement. So if you can take 1 minute each. Hello, Shailid. If you can take 1 minute each, while there's a lot of talk on competency-based medical education, on the ground and in reality, if you can, from your vast experience in the space, let us know if it is really happening on the ground, number one, and two, what would be the biggest number one challenge, to bridge that gap, right? Maybe we can start with sir from the left, please. So, sir, one thing which is happening on the ground with competency-based education and one biggest gap you think which we need to bridge?
Well, good afternoon and thank you very much for having us on this panel. Now CBME is here to stay. So one good thing. So from knowing we are going towards performing. So earlier on, the focus was always on knowledge, acquiring knowledge, and when somebody's acquired knowledge, it is presumed that he or she will be able to perform. But now the focus is on performance, that is competency. So that's something which is envisaged, that's something which is we are planning. And as far as the challenge is concerned, I think the faculty training to a large extent, I think, is essential.
Dr. Nayanjeet, please.
Yeah, thank you, Dr. Santosh, and a very good afternoon to everybody. It's a privilege to be here. I just echo, sir, in saying, first of all, the competency is much wider than skills. So when we assess the performance of a medical graduate in the rural PHC of Meghalaya, where I come from, where many a times, there is no electricity also, compared to in an ivory tower of a sophisticated medical college is kind of different. And therefore, how do we train our people, both in the medical schools and nursing schools, as well as on the job in their workplaces, requires a lot of overhaul. And this is where faculty training is critically important, not only from a cognitive perspective, as you said, but also from a constructivist approach, like an adult learning and social learning, where people learn on the go, in the job. So with that, I would like to open this forum.
Dr.
Thank you.
Nanjit, also the biggest challenge, please.
The biggest challenge is, first of all, we have a lot to do and we have a lot of gap, particularly in terms of the overall ecosystem is extremely fragile. There's a lot of exigencies every day from the policy makers to the medical school teachers to those who perform in the PHCs and CHCs. So while addressing the infrastructure, how do we continuously innovate? So there's a cultural shift that is needed. That's a big challenge. But I think there is a silver line beaming across the country at this moment. Thanks.
Thank you.
Thank you. Looking at competency-based evaluation, I think it's good because we are testing performance, we are testing skills, but more importantly, I think it's becoming even more important in today's era of AI, etc., where if you are asked to give an assignment, you can just make it up, and here we are going to actually see the person doing something in front of our own eyes when you cannot get any assistance. Is it being done? I think the scenario is very variable. Some institutions, it's being done extensively. Others, it's lip service in the name of competency-based evaluation. The challenges to me are basically two. We have very large classrooms today for undergraduates, and doing competency-based testing for such a large classroom means we need a lot of time. And that actually means that our examinations become very prolonged, and that takes away time from teaching, or it does not get done. The second thing is, there are a few scenarios that have been made, and only those skills, only those competencies are being tested. And students know that these are the competencies that are going to be tested in the exam, and they are preparing for that. What we need to do is test a lot of competencies. We need to make up those scenarios right then and there and test them so that they are not prepared. It's not more of a hoax. It should be a real impromptu testing of skills.
Dr. Rekha.
Good afternoon, everyone. It's a pleasure to be here. When the National Medical Council introduced CBME, there was a lot of enthusiasm amongst faculty. We thought finally there was a measure by which we would be able to standardize the quality of graduates who leave the portals of our college. And to some extent, the CBME achieved this. But one of the biggest challenges that we face during the implementation of the CBME is one, faculty acceptance and transition. The second big challenge that we have is the amount of resources needed for this. And this is in terms of the infra, in terms of faculty, in terms of the time. And the third most important challenge, I feel, is that it has resulted in greater fragmentation, with some departments having full ownership and some departments having full abandonment.
It's exemplary privilege to be on the panel today here on CBME. Lewis Carroll in Alice in Wonderland tells us that if you don't know the road which you are taking, any road would you take there? It underscores the importance, relevance, and significance of competency-driven approach. But having said that, if really wanted to talk about reshaping and redesigning medical education for the 21st century, we will have to see not competency approach in isolation, but together as a reforms agenda. Having said that, the challenge that I pursue as a part of the competency-driven approach that we have adopted is that still a tremendous gap between educational competencies and the work competencies. Because as a faculty in medical institutions, we have our own approaches of looking at these are the competencies we expect our graduates to accomplish for. But when we actually get into the practice, then there are work competencies and there are expectations around that. So how do we bridge the gap between the educational competencies and work competencies would be a challenge that we probably would need to respond to. Thank you.
I believe that CBME is an educational reform, but more than that, we should start seeing it as a healthcare transformation tool. And from what I've experienced working in Canada for the last 20 years as a healthcare strategist and a registered nurse, the real success of competency-based model lies in mindset change. The competence and the education is so deeply rooted in the mindset and the integrity of healthcare system. And in India, we are at a very important turning point, and I'm really grateful for Pulse to organize this conversation.
Thank you. Thank you, everyone. Dr. Rekha, Dr. Rakesh made a very important point in terms of the role of artificial intelligence in competency-based assessments. Now, it's very easy these days to use artificial intelligence tools, to churn out papers or research studies, etc. So my question to you is more as the dean of a very renowned medical college. How do you translate moving from classroom to clinical postings and clinical work? How does competency-based medical education fill in that gap?
So when we're talking about competency-based medical education, it is important for us to be confident that the student has the necessary skill. And towards this, the role of simulation labs, the presence of AI-enabled tools are very, very essential because it allows the student to practice any number of times before they actually come up for the assessment. So when you have, say, a VR tool, for example, in laparoscopic surgery, it allows the student to practice multiple times, dissecting the calyx, clipping the vessel. It also has the mechanism to track the amount of tremor that you have, the amount of time taken to dissect it off the GB bed. So the student has a real-time feedback. And this is outside of any kind of a subjective assessment that would happen. And thereby, once you have this kind of an objective AI analytic tool, they understand that their competency has to improve. And this goes better, they get better and better as they practice before they actually come up for a DOPS assessment, for example.
Wonderful. Thank you for sharing that. Professor Sanjay, from the public health perspective, being the president of the Public Health Foundation of India, so CBME has always been viewed as something which is very individual, patient-centric or patient-driven, assessments and education and training. From a public health perspective, moving from classrooms to communities, what do you think CBME can do to add value to the communities?
It's clearly that the health professional education, including medical education, has not kept pace with the 21st century challenges. It's very clear. It really requires authoritative re-examination of overall approach for the medical education in 21st century. Having said that, we really need to see the gap currently exists, a disconnect currently exists between the medical education and health systems. If we think about, at the beginning of the previous century, the three reports, the Flexner one for medical education, Vention Rose and Goldmark, they really redefined the health professional education, connecting science with the curriculum, and then around mid-century we have problem-based learning approaches. But what we really need today is building the connect between the medical education and health system. And when I say health system, it doesn't mean only a public system, basically. From that perspective, we really will have to see that how do we do that. And we can do that using two approaches. One, and those are reforms basically which are critical, and strategies for that matter. the institutional strategies and instructional strategies. For instructional strategies, we will have to bring the focus on transformative learning. But the transformative learning is a fundamental driver for the instructional strategies. And what transformative learning is all about, moving from informative learning to the formative learning, where in informative learning we talk about transfer of knowledge and skills, but moving forward of adding values, ethics and moral and other things. But moving further forward as a transformative learning where the focus is on creating change agents, from that perspective and leadership attributes. Because informative learning would create experts, formative learning would create professionals, but we really need change agents and leaders in the field of health sector, and therefore transformative learning is critical. The another reform that would be required is interdependence of the education. We cannot actually deal with any profession in isolation. We work in teams, but we teach in isolations. That also need to be factored about. From that perspective, the connect with the health system will bring those competencies which are critical for the medical graduate to work as a functional public health professional. We also need to focus on that because knowledge is changing so fast that how do we create a lifelong learners? It's not that something they would learn because creating those lifelong learners is important, and from a public health perspective, whole scenario of public health changing. So which are those public health competencies, which also include cross-cutting competencies? Technical competencies are core, but critical thinking, reflection, and so on, all other competencies are so important to create them as a lifelong learners, because we have to keep in mind, we create our graduates for the future, not for our past.
No, absolutely. I think there's a lot of talk on soft skills and competencies related to that. And thank you for sharing that. Shailidhi, we are very fortunate to have you. The rest of the panel, all of us are medical doctors. From your perspective, from the nursing education sector, which is a very, very critical component overall of the medical education sector. And from the Canada experience, Canada being a more mature, country in terms of the CBME model, I have two questions. One, in terms of nursing education, how do you see that the CBME applies? Because there's a lot of learning there. And the second piece is, what can India or Maharashtra in general learn from a more mature, model which is used in Canada?
Those are my favorite questions. I believe the regulatory bodies, they have the quality
Move the mic a little.
The regulatory bodies have the quality improvement practices in place. I believe India is evolving very fast in that term. But creating the assessments and not judging and assessing nurses just based on skills. What I have observed in last 5 years that nurses have opened a lot of academies to improve skills. But if we talk about evaluation and analyzing the patient data, identifying the system gaps, and implementing the improvements, it is so hard for a nurse to go and say, I want to improve this. It will take years to build that, but I think now is a turning point for India to start listening to nurses, because they're problem solvers. They are the future nurse scientists, leaders, innovators, and entrepreneurs. And I am proudly sharing this on this stage that I'm also a member of SONSEAL US. And when you don't have a chair at the table, you bring your own chair. And that definitely is a competency as well. Thank you.
Thank you. Dr. Rakesh, it's what we have heard so far has been more in terms of the undergraduation area. You have vast experience in managing postgraduate programs. And, my question to you is in terms of, one, what's happening in the post-graduation space, but the question prior to that is, what skills or competencies should have undergraduates already learned before they come to post-graduation, or is it too late?
So I think I'll go by my experience of what I'm seeing the current graduates lack when they enter post-graduation. I think communication is a very important skill that a person must have by the time they graduate out of medical school. This is communication with the patients, communicating prognosis, explaining the different treatment options, helping them, negotiate through those options, being able to give bad news. And one is finding that undergraduates today are not really good at this. A part of it is because there is large class size, so they are not exposed to this. Partly today's undergraduates don't go to the wards in the evenings, in the nights, at one time they used to. The other thing is, I think they need to learn ethics. Ethics is inherent to medical practice, and they need to understand ethics as related to patient care, ethics as related to research, ethics as in relation to relationship with the industry, relationship with pharmaceuticals, and I think that's something that we need to teach our undergraduates. They need to understand what is, technology versus empathy. They're all trying to look at, when they enter post-graduation, they want to learn techniques while not being, looking at whether they are, they need to understand the futility of medicine at times in certain situations. They need to have better computer skills. Today, I compare my daughter when she finished her engineering degree and the kind of skills she had in writing versus what our medical graduates can do. And some of this actually does not even need to start at undergraduate MBBS level. In schools, we have taken away when I was in school, we used to have something called Pressy writing. People had to take a long paragraph and say it in 3 sentences. And I think that's extremely important. So I think there are a lot of skills that need to start early before they come to post-graduation. They need to, Dr. Zodpe has already said, they need to learn how to be lifelong learners. And I think that's something that is essential if they are going to do post-graduation. I think I'll stop here. There are a lot of things. If in BE courses, BTech courses, we can teach management, why not in MBBS courses? So there are multiple issues. Thank you.
Thank you, Dr. Rakesh. Dr. Nayanjit, from your experience in Meghalaya, which is very, very vast, you've mapped various clinical touch points from rural ANC visits to emergency labor room visits. What has been some of the learnings there, if you could expound on what work you have done in Meghalaya, and also what can a large state like Maharashtra, learn from Meghalaya's experience?
Yeah, thanks, Dr. Santosh. I think part of the answer is embedded in what Dr. Zorpe and Madam Rekha and Madam Shiladi has already said, and very articulately Rakesh Agarwal sir has already referred to. In Meghalaya, we introduced about 3 years ago something very interesting called techno-managerial skills for all doctors across all cadres in almost every facility, as well as more than 1,800 plus nurses across the state. So techno-managerial skills included change management, communication not only in terms of interpersonal, but persuasion. Because persuasion is not only about convincing a patient and a community of an intervention, but also doing upstream advocacy with their bosses in the state system. We introduced resource management or stewardship. So stewardship included not only responsibility, but accountability of their roles. So, and similar stuff. It went very well, and there's a demand in the grassroots to do more refresher training on techno-managerial. Then we introduced leadership training for trainers, competency-based leadership training, where given the context where we have extreme resource constraints, both in terms of human resources, but also of infrastructure and equipment and ecosystem, how do our trainers innovate in the context? And that's exactly where I'm aligning with Rakesh sir in terms of designing new scenarios that are relevant for our context. We have recently done a massive, comprehensive competency mapping exercise for 4 clinical cadres, from all MOs in every facility to all staff nurses in every facility to A&Ms in the health and wellness centers. Imagine the touch points where a pregnant mother is entering into a health and wellness center. She undergoes multiple encounters, not only clinical, and most of them are actually non-clinical. How does an A&M deliver her role, not only in terms of clinical, but also functional, technical, and behavioral? That's in alignment with the FRAC framework of Mission Karma Yogi, Government of India. So now we are trying to standardize the capacity building programs for across the cadres in terms of role-based rather than rule-based competency development. It's a long story, but hope that gives you some ideas to what we are doing. Thanks.
And how can we scale this up to, say, a state like Maharashtra?
I think the context is extremely important. Whereas the guidelines do come from Delhi, and there are international bodies, but every state has the ability to innovate in the context while not siding away with scientific evidence, but at the same time not discarding the cultural nuances and the local adaptability. It's the time of agility, agile management. I think every state must invest in local contextual competency development, not only for the graduates, but also for trainers, because teachers are not just medical college teachers. They are trainers, they are mentors, and they are coaches, and every role is different. So we need a phenomenal capacity building program for teachers in the entire country in alignment with 21st century skills is what I would like to offer. Thanks.
Thank you. Dr. Vivek, as somebody leading a large multidisciplinary university like Bharati Vidyapeeth, how do you ensure that competency assessment goes beyond skills into actually translating into on-the-ground work?
Yeah, again, a very good question. Actually, that's the goal. I mean, how do these competencies lead to demonstrable improved performance? Two things I'll say. I mean, how one learns skill. I mean, earlier when the students come, they are novices, from novices to early beginners to competent to expert to proficient. So there is a map as to how we are acquiring the skills. And again, for development of these skills, or if I may say it, competencies, it's not something like a rocket science. I mean, how do we learn any skill for that matter, whether it's driving a car or swimming or for that matter, any skill. So it's practice, practice, practice. So I mean, more you practice, more you hone your skills. But mind you, practice is not just enough. Practice has to be backed by feedback. Because if I am practicing in an incorrect way, then there is someone who needs to coach me, guide me, tutor me, correct me. So I think if this is to result in demonstrable improvement in the performance, then obviously there have to be opportunities for hands-on practice, and it has to be coupled with a feedback. Unfortunately, our faculty are not taught in giving feedback. We are taught in receiving feedback. I mean, we'll say that, okay, I mean, how did I conduct a lecture, or how did I conduct a session, and so on and so forth. But when it comes to giving a feedback, that's something which we lack. So how do we give feedback to the learner in a constructive manner? That's something which we all need to. So if the competency-based model has to succeed, then we have to ensure that there are enough opportunities for practice, and the faculty is trained to give feedback. See, we can take examples from the sports area. In sports, I think you will see the best of the players, but they still have a coach. They will tell him that, okay, you're doing this right or you're not doing it right. I think you can watch Atul Gawande's TED Talk. I mean, as a surgeon, in 20 years after doing surgery, he says if he wants to improve on, how do you do that? He hires a coach. And then the coach tells him that, okay, this you're doing it right, or this you can do it better. So I think that's something which we really need to imbibe if we really want to develop or see that the competency-based model succeeds. And for practice, I mean, I agree that we may not have as many real patients, or it may not be ethical to have, particularly sir is saying, Rakesh sir is saying that we have large classroom, that's a reality. So we have large classrooms. So how do we go about it? So obviously simulation is something which is here, which we have to stay, but it need not be always high-end, high-fidelity, high-tech simulation. It can be simple task trainers, mannequins, maybe simple models or dummies or torsos. There can be simple things, even it can be standardized patients, and we can have our own small, simulations on our own ways where we can innovate. There are so very many examples in which it can be done. So, primarily, I would say that there has to be intent, there has to be clarity. If intent and clarity is there, then I'm sure the ways can be found out.
No, but thank you very much. You make two very important points. One, in terms of giving feedback. I think that's also a cultural issue, with us Indians as a whole. We are used to receiving feedback and not giving feedback. I think the second point about having a coach, I think, a lot of corporate organizations are moving in that way. All of us have coaches within the organizations, especially to mentor and guide, younger professionals coming in. So I think, how this can be translated into the medical education space, I think is a critical component. Dr. Rekha, while, it sounds very simple, how does it actually work in a medical college? Moving from competency-based education involving assessments, how standardized this is? I know, the institute you come from is very well renowned, you have the resources, but how can this be standardized across institutions in the state, in the country, and, whether it is private or government? How can we bring that standardization in CBME?
So I have the, distinction of having worked in 2 private medical colleges in the south and across 2 states. So I have realized that there is a huge variation in the quality and the standardization of any kind of assessment. And you find that when the National Medical Council introduced the competencies, that was some kind of standardization. They introduced, these are the skills that you have to do, these are the ones that you have to know, and these are the ones that you need to know how. But having said that, are we confident that at this particular point, the standardization is happening, say, from a rural based medical college to, say, a premier institution in a tier 1 city? It's not happening, and you find that this is a huge challenge. Everybody talks about getting onto the tech bandwagon as a solution. I really don't think that only technology is going to be the solution. I think faculty will be the backbone of this process of standardization. Now, even in our own medical colleges, when we are looking at workplace-based assessment, there is a huge difference, and I think that we need to introduce a system of internal calibration, whereby one student is assessed by more than one faculty, and then we have an internal conversation as to why we are having that variation and ensure that calibration happens. The other thing that we need to do is talk about resource sharing. I think instead of every college having to redo case-based scenarios, workplace-based assessment, 1-minute perceptors, if there is a little bit of openness and sharing, I think like we have in the NHS, you find that the standardization happens across the higher education institutions. That would be a way forward. But I also think that inter-institutional audits could be something that we could introduce, whereby, not in a hostile fashion, but more often in a spirit of willingness to improve, that we actually visit each other's colleges and learn from it, and then we are able to introduce standardization in the region, in the state, and then we'll be able to move forward nationally. Now, you find that another thing that we need to think of when we're talking about assessment and introducing CBME mainstream is that we shouldn't be looking at the assessment as an end product. It shouldn't be like, you need to have a time set apart for assessment. Instead, it has to be on the go. As we take ward rounds, we do the formative assessment. And like Sir rightly said, the ability to give feedback has to improve. I think as a nation, we do not take feedback very well. And I think we need to understand that the ability to take feedback, the ability to give constructive feedback, and to make sure that this gets incorporated so that the student doesn't repeat the same mistake the next time. Now, the other big thing that we can do to ensure standardization is that we need to give faculty more time to do meaningful teaching, mentoring. So there is a role of technology coming in, where the tech system is able to calibrate that you require X number of points to be able to progress to the next level. So there is no human element at all. You find that the student has done these particular tasks, then straight away you have the time released now for the teachers to be able to do more focused teaching, to be able to give that input, to talk about the little tweaks that make a difference, for example, in a surgical specialty. Now, the role of mentoring is something that we need to take very seriously. And you find that if we have like-minded mentors across institutions, we'll be able to come together and develop blueprints that will ensure CBME is not merely rhetorical, but is a reality. And you find that the last suggestion that I have is that we could introduce something called as an annual review of clinical performance, where we actually are able to standardize that a student has X number of skills before they move to the next level of training. And when they are doing rotation, we have to make sure that rotation happens in a fashion that exposes them to all elements. For example, in obstetrics, they need to rotate through the labor room, through the high dependency unit, through OT, through the skills lab, in order to ensure that their exposure is truly well-rounded, holistic, and that way we will be able to introduce standardization. But standardization we can't roll out en masse. We'll have to do it in bits. Like I said, probably Western Maharashtra initially, and then the whole of the state. And then we'll be able to connect with like-minded people across, and then we'll be able to introduce standardization. The way forward is faculty, committed faculty, adapting good technology.
Thank you very much. I think faculty being the backbone is the critical take-home point. Professor Sanjay, India has what we call the double burden of disease, probably even the triple burden of disease now, with obesity emerging as a major cause of illness as well. While CBME can churn out clinically competent doctors, how can we ensure that our doctors are trained in data analytics, health systems research, and other components of public health through CBME?
Thank you, Santosh. Our national bird is peacock and not the ostrich. So if we really wanted to fix around the problems, we'll have to look around where are those problems. Having said that, medical education cannot really function in isolation. I made this point earlier, but in now different context. We really need to build a bridge between the health systems and medical education. Take an example of primary health care or a comprehensive primary health care. How much exposure, experience, and expertise that we would build for an undergraduate students. We expect them to go to primary health center or even a practice comprehensive primary health care. But the ecosystem that we have in medical institutions, which are primarily tertiary institutions with focus on secondary and tertiary, health care, is a challenge. So I think we will really have to see that how do we bring the focus to the public health practice as a part of medical education. Because public health education that is irrelevant to our national health priorities and diverse from public health practice is a lost opportunity from that perspective. So that's the first point that I wanted to make, that how do, the bringing that focus to the public health practice will build on their public health skills. You talked about disease surveillance and monitoring and evaluation and dealing with the programs and so on. The second important, point that I wanted to make is, fortunately, we have a national education policy that is for the higher education. That was released in 2020, 5-6 years back. That policy is really forward-looking policy. But for medical education, we really do not have that kind of an approach which has been adapted for the higher education in India. For example, now creating positions for a professor of practice, as per the University Grants Commission. We really need to see that how that practice component is brought as a part of medical education. That's the another point probably is critical. For the public health training in undergraduate medical programs, community is our laboratory. And of course, it is very integral part of our medical education also. But the challenges are around implementation. It's not that something which we need to do a new way, but it's already there, but we really have to see that how do we implement those, and community-based education actually happens. Students learn in the communities, they go to the families, they see the interplay of various factors beyond the health. Because, we have to really look at health beyond the corridors of medicine. Because health is impacted by several factors. And that perspective needs to be brought as a integral part of our medical education. Because the conditions in which we live, work, age, all have influence on our health. And therefore that multidisciplinarity beyond the medicine needs to be looked at from a health perspective. Because health should be the focus and not the medicine actually. Because medicine is an instrument to keep us healthy. I think that philosophy needs to be integrated and percolated. And that's how then we will be able to create the graduates which are aligned to the public health approaches, principles, and techniques and tools. Thank you.
Thank you. Thank you. Shaladi, in Canada, nurses play a very central role, not just in care delivery, but also in terms of quality, in terms of research as well. Give us a couple of points which India can adopt within the competency-based framework, to make these teams more, interoperable and integrated.
When I went to Canada, I did my nursing from PGI Chandigarh. I did my Bachelor's of Science in Nursing from there, and it's a WHO recognized college. And I was privileged to, do my clinicals in tertiary hospital. But when I went to Canada, I worked in long-term care homes, community care. So where did I learn from? It was all web-based learning. So Registered Nurses Association of Ontario has best practice guidelines on their website. It is all about how research-based, evidence-based practice is so accessible for anyone who's working anywhere. And the College of Nurses of Ontario, which is a regulatory body, also has their practice guidelines and standards, and they update if anything changes. I think that really improves the competence of nurses. And I think, as respected, so he was mentioning about coaching. I have personally coached more than 4,000 nurses who have migrated to Canada or North America. It's a blame-free, shame-free environment that we need to create. If there is a blame and shame, no one is going to learn competent care. So it's all about creating that environment.
Thank you very much. Dr. Vivek, assessments is probably the weakest link within the competency-based framework, right? From your experience at the university level, how can this be improved? How can this be standardized to make sure there's a fair assessment across the framework?
Well, I cannot agree with you more than the statement that assessment is the weakest link. Yes, certainly it is the weakest link in the present CBME system. We have evolved a new system, or we are evolving towards a new CBME system. But as of now, the assessment remains with the old system. We still, for the clinical examinations, we still have a long case and a short case, and that summative assessment and hardly any formative assessment, and so on and so forth. So obviously, I think we need to understand the adage that assessment drives learning. If assessment is linked to learning, then learning will happen, and we will know at what level the students are or the learners are progressing. So at present, certainly there is a disconnect, I think the students have a different perception for the matter. I mean, this will open up a new Pandora's box, so I don't want to comment because the NEET and other things, I think they spend hours together studying for the NEET examination rather than focusing or honing their clinical skills or getting good marks in their clinicals or for that matter, their regular examinations. But that aside, so I think we need to bring in, as madam has said, we need to bring in lot of formative assessments. Now again, again our system, we need to introspect. We have internal exams, external examiners. When some of the international guests come, so they say that, what is this external examiner? Don't you trust your own people? So that's again something which we really need to look at, that okay, why cannot we have 60% of the continuous or internal assessment and maybe 40%? I'm just giving a broad thumb rule. It can be 50-50, it can be whatever, experts can debate, discuss about it, but there has to be an element of continuous assessment. Now you'll say that, okay, if as many students have to look at continuous assessment, where do we have as many faculty and so on and so forth? When we're talking about starting some OSCE or other things in our university, they said that, okay, if we take OSCE, there's only 10 faculty in one department. But why can't we pool our resources? It's not necessary that as I'm a surgeon, if I'm a surgeon, I can certainly, do some basic OSCE assessment for maybe pre or a paraclinical subject, but we need to come out of that mindset. This is my domain, this is my departmental boundary. For that matter, for continuous assessment, why there cannot be a near peer assessment? Why there cannot be a postgraduate student first year or a second year assess the first year or a second year or a clinical medicine subject student? So I think we really need to think little out of box. If we space in the assessments frequent, the formative assessments have to be frequent, they have to be with feedbacks, they have to be for improvement in the learning. So that's possibly, I will say that if we want to really ensure success of the CBME model, then we also need to bring reform in our assessment system. The focus, which is primarily on summative assessment, has to shift to formative or a continuous assessment. And for continuous assessment, if we have a challenge of numbers, we have to find our own innovative solutions as to how this work, and that if the freedom is given to the institutions now, everyone, all of us look at the regulatory bodies, regulatory councils, they'll say that, okay, you do like this, and that's been followed. So I think that some flexibility, some freedom, and some trust within our own faculty. Fine, there may be few, minuscule people who would maybe take advantage of the situation or disadvantage, but by and large, majority of the people, if they are in teaching profession, they know their responsibility, but it's just that we shy away from, believing in them, or we just, I think, we have our systems where कहते हैं घर की मुर्गी दाल बराबर. So it needs a fresh look and a little different thinking.
And I think with the school system moving towards continuous assessment, I think it's a natural course of action to move our medical education as well in that direction. I'm going to take your point to Dr. Nayanjeet. You spoke about the overload in terms of preparing for NEET exams versus clinical competencies. But Dr. Nayanjeet, we spoke about techno-managerial skills, digital capabilities, communication, empathy, a lot of things. Sir spoke about ethics. Do you see a system overload or a curriculum overload when we are talking about so many things, plus medical education is by itself quite tedious? So how do you balance and bring that balance? Are we not overloading students as well?
Yeah, thanks, Dr. Santosh. I was frantically taking notes from all the stalwart panelists so that I can gather my answer. Apparently, there is an overload. And I think, in my opinion, the critical reason for the perceived overload is because we look at empathy or compassion and digital literacy as separate domains. We look at clinical competency as a Midas touch, and everything else is secondary. The world has changed. In fact, as I'm listening to the co-panelists, I'm reflecting on what happened, let's say, some 5,000 years ago. In 7th century BC, Saint Kapila came up with his, I think, the Vaisheshika philosophy. India gave to the world 9 philosophies. One of them is Vaisheshika and the other one is Sankhya, the 2 latest ones. There they talked about the detachment. Detachment is a skill. So when we talk about compassion, compassion is not a moral value or a mandate anymore. It is an autonomic nervous system, regulatory mechanism we teach in the physiology departments only to pass an exam, not as a skill that the students can imbibe, practice in their day-to-day affairs as a student as well as a practitioner when they graduate. Remember, India has given this to the rest of the world. Today, all the neurocognitive research is based on mindfulness, or at least 99% of them. Worldwide, mindfulness has gone from Buddhism. So that's practically from India, and originally it is the Sankhya philosophy, where detachment is practiced as a neurocognitive skill. So today, science has come back to us as a Western domain, whereas it actually originated in India. That's why I said it's a perceived overload. And very much echoing with what Dr. Vivek sir told, how do we relook at the entire system? In India, in a public sector hospital or a facility, a doctor or a nurse meets more than 100 patients in a day. And the professors who wrote the Western textbooks, I have full reverence to them. They see 10 patients in a day in the most busiest clinics in their well-guarded ivory towers, and we call them mass casualties. So our context is different. And this is where we need to practice compassion in teaching, practice compassion in healthcare. Now, a couple of offerings I have to see how it resonates with maybe the Maharashtra government's approach. One is the MMO framework, where means, motivation, and opportunities can be assessed. Now, you have trained a doctor or a nurse in conducting a delivery in a very ideal laboratory setting called a labor room in a medical college. I will like to test her clinical acumen in terms of whether she knows the basic knowledge of labor, the different stages, the different challenges, and the different interventions. But when she is posted in a rural, let's say Gadchiroli district, or let us say in the South Garo Hills, almost flooded perennially, in a primary health center or a community health center, where she has no power supply, she has no equipment, her ambu bag is not working, how will she perform? So how do we, and that's exactly when I echo with Rakesh sir as well, how do we create scenarios in which these budding professionals will go with that's called competency. So they are able to solve problems like Madam Shiladi was also talking about. Opportunities are the infrastructure, the equipment, they vary. But the means is the internal motivation, the skills, the knowledge that we give them in diverse scenarios. And then comes motivation as an external entity. So external motivation could be rewards, incentives, but mostly I'm telling you, a doctor or a nurse has become a doctor or a nurse because he actually is internally motivated to serve the suffering. And that's where I'm also offering a 3-axis approach, if you would like to consider this. The first axis is clinical, there's no question about it, non-negotiable. The second axis is digital stewardship. There is no question that a doctor or a nurse must be able to operate the gadgets, must be able to interpret the readings in the monitors, but also must be able to manage the electronic health record. There is no question. And for that, the teacher has to be ready, because if the teacher says, in our days, we had no computers and therefore there's an excuse for me not to learn, you are no more a facilitator of learning, because teaching has changed. In our times, a teacher was the source of information. Today, no more. Today, a teacher is a facilitator of learning, like Sanjay sir said, lifelong learning that the student is going to become. And in that becoming, there is social learning embedded, there is peer learning embedded. Even Vivek sir talked about peer evaluation. So this is where stewardship of technology and digital literacy is non-negotiable. And then comes a third axis of assessment that you may consider is how is this person trying to be compassionate, even in a role play simulation, okay? Are there objective signs of compassion that we can measure? And this is where I think internal assessment, as Vivek sir was saying, is so critical. An external examiner will not be able to assess them until and unless the internal fortitude has been developed progressively. With that, I would like to end. So thank you so much.
Thank you. Rakesh sir, a very important question. I think a lot of us have spoken about more from the perspective of undergraduate education, nursing education, postgraduate. So it's a journey. And, you know, unfortunately for all of us who've been through that journey, the higher you reach in the medical education practice, you know, empathy, compassion, you know, some of these fundamental values kind of diminish. You've been training a lot of, you know, doctors who are in the DM program and above. You know, how do you see that journey evolving? Is it too late to impart some of the qualities what Dr. Chaudhary had mentioned?
I don't think it's ever too late. Of course, it helps if you catch them young and do it at a younger stage. The way I have done it is basically you have to treat them as partners. We really need to tell them that they have a huge responsibility. So some sentences for my residents, you know, how they need to, you know, suddenly have a jugaad at times, is that look, if you have done your MD, if you had not joined medicine and if you were somewhere else, you would be a district magistrate or a superintendent of police with a right to open firing on a group of 10,000 people. And here you ask me what antibiotic I should be using. You know, you really need to tell them that we need to empower them first. Secondly, I think you lead by your personal example. You need to show them, at least I learned, whether at undergraduate level or postgraduate level, whatever I learned about empathy, about behavior, about treating the patient with respect from my faculty members. So you really need to you have to act as a role model. You have to show them what is supposed to be done. You can't expect them, you know, unfortunately in our country, very often teaching is very different from what you practice. You tell your son, always tell the truth, and then the phone bill rings and you say, tell them Papa is not at home. How do you expect the child to then speak the truth? So if you behave well with your patients, if you treat them with respect, if you show them in the outpatient that when a patient of viral hepatitis comes to you or SLE comes to you, you yourself say, are you wanting to have a child? In that case, you know, what is to be done? They would be reluctant to ask. You have to make them aware that these are other issues that patients have. If you ask a patient, how much does a visit cost you, and can I give you a prescription for 6 months rather than call you back after 3 months? That's what they learn. So I think at every level, we have to remember that as faculty members, we have much more duty. And let me give you an example of what I thought today morning sitting at the Hyderabad airport. When a pilot or an air hostess is at the airport in that surrounding, you can never see them sitting loosely. They are always as if they are being observed. They stand for a profession. How many of our faculty members will wear a white coat, will wear a tie? In a corporate hospital, an MBA tells you, please wear a tie, you will. In an academic setting, you have to show by your example that this is how behavior has to be, this is how compassion is, this is how if somebody asks you the way, even if you are in the round, you stop, you show them the way and then move ahead. You show them that you have to hold the door and wait for a patient to cross and then you will cross. It can be done even at any stage. It's never too late. I think it can be shown even to faculty members, leave aside to postgraduates. Thank you.
Thank you very much, sir, and thank you once more to all the panelists. I think it's been a wonderful and very enlightening, session. It's a complex subject, and from your vast experience, you can relate to, right from undergraduation to DM levels to nursing education, and we haven't even, touched the surface. You have, dental, allied health, and so many more areas to cover under the competency-based framework. Shailaji, you have a last point.
I want to add something that we are in a conceptualization age, not an information age that has gone. As he was mentioning, anyone who has knowledge, anyone can have it, have a chat GPT and have knowledge. But how many of us can conceptualize different things and integrate them and provide compassionate care to our people in our community, because only competent healthcare professionals can lead the future of healthcare.
I think compassion is the takeaway word for all of us, and it's great that it's coming.
Yeah, when I was a patient myself, I had a premature baby and I was on a bed rest. In Canada, an Indian nurse came in and she's like, "How are you today?" She cannot ask someone who is on bed rest and come with a laughing smile. And on the other side, there was another nurse who had competence, sat beside me and asked me, how I was, held my hand, and talked about how maternity photo shoots are important, but being on bed rest, having to think about a premature baby, having to think about ICU, all that matters. So I think competency is something which is a necessity. Yeah.
Thank you. I think we are stuck to the time, and we'll wrap up the session. So over to the organizers, please.
Can we have a huge round of applause, please? And thank you so much to our moderator and panelists for that extremely insightful conversation. Today's discussion highlights the importance of aligning training with real-world clinical needs, ensuring that our future clinicians graduate with competence, clarity, and confidence. To express our gratitude, we now invite Dr. Sudhir Medhikar, Joint Director, Medical, DMER, to kindly join us on stage for the felicitation of our moderator and panelists. Can we have a round of applause, please, guys?